My name is Shannon Allen, and I'm a doctoral student at North Central University studying the psychology of trauma, crisis, and violence. Today's presentation is on torture and trauma. Today's presentation will cover the following torture and trauma topics specifically related to refugees and asylees: definitions and data, similarities and differences between torture trauma and more common types of trauma, cultural competency in psychology, assessment challenges, culture-based coping strategies, culture-based verbal and nonverbal communications, and culture-based stigma as a barrier to treatment. Trauma is the emotional response to exposure to distressing or life-threatening events or a series of events that impacts an individual's physical, mental, emotional, social, cognitive, or spiritual well-being. Torture is defined by U.S. law as an act which is intended to inflict severe physical or mental pain or suffering, and committed by a person acting under the color of law upon another person who he has under his custody or physical control. The statute goes on to describe mental pain or suffering as a prolonged psychological injury resulting from the purposeful infliction or threatened infliction of extreme bodily pain or suffering, the administration or threatened administration of mind-altering substances or any other substances or procedures that may severely disrupt an individual's personality or their senses, the threat of imminent death, or the threat that another person will imminently be subjected to those as mentioned earlier. The terms refugee, asylee, and asylum seeker are often used interchangeably. However, some differences relate to how and where they receive a refugee or asylee status. Both need to demonstrate that they are fleeing their country due to persecution. Persecution is often based on religion, race, nationality, membership in a particular group, or political opinion. Other reasons that they may flee are due to dire environmental or economic catastrophes. Refugees typically flee to neighboring countries where they wait at camps for the United Nations to process them. They will often wait for years until it is safe to return to their country or until they can resettle in a third country. Asylees flee for the same reasons as refugees. However, they typically go directly to the country they wish to seek refuge, where they apply for refugee status and are granted asylum. Currently, there are more refugees and displaced people in the world than at any other point since World War II. According to the Centers for Victims of Torture, an estimated 44% of refugees and asylees living in the United States experience torture in their home country. This map represents the most populated refugee camps. Many camps are gathered around the same location in Africa because of the long-fought war in South Sudan. The Sudanese have endured appalling torture, such as both children and adults being run down by tanks, girls as young as 7 being raped, babies drowned and smashed against trees, and many starved to near death or death. An estimated 65% of females and 36% of males at African refugee camps were sexually abused before escaping. As you can see in this map, the locations of refugee camps are by and large consistent with areas where torture is more concentrated. From 2010 to 2020, refugees and asylees came to the U.S. from Myanmar at 20.8%, followed by 18.2% from Iraq, 12.9% from Bhutan, 11.7% from the Democratic Republic of Congo, 9% from Somalia, 3.8% from Iran, 3.7% from Syria, 3.3% from Cuba, 3.2% from Ukraine, 3% from Eritrea, 10.3% from all other or unknown countries. Research has suggested that torture survivors from southeastern European cultures had substantially more post-traumatic stress disorder, more commonly known as PTSD, symptoms than survivors from Central African, Southern Asian, and Middle Eastern cultures. This resettlement map is pretty self-explanatory. Iraqi refugees primarily resettled in the light blue states. Somalian refugees primarily resettled in the lighter purple states. DRC refugees in green states. Myanmar refugees in orange states. Cuban refugees in royal blue states. Eritrea refugees in white states, Bhutan refugees in dark blue states, and Ukraine refugees in the darker purple states. However, bear in mind that this does not represent any movement after their initial resettlement. Men, women, and children seeking refuge or asylum in the United States are pretty equally distributed, with children under 14 making up 31%, men 15 and older making up 36%, and women 15 and older making up 33%. As seen in the table, refugees and asylees in the United States are predominantly Christian, followed by Muslim, Hindu, Buddhist, other, and unaffiliated. So, this demographical information should give you some insight into how to culturally prepare to work with a diverse range of patients. The most common torture techniques associated with psychological sequelae in order of methods most frequently used to those used the least are severe beatings, threats of bodily harm, humiliation, verbal sexual humiliation, forced incongruent acts like violations of the victim's religious or cultural norms, social isolation, hygienic deprivation, being tied down, nutritional deprivation, sleep deprivation, sensory deprivation, such as being kept in a dark room or being blindfolded for long periods of time, health service deprivation, forced labor, hair torture, like having hair pulled out or burned off, or being dragged or hung by the hair, prolonged standing, undressing in front of others, cold torture, like forced exposure to cold, and ear torture. So it shouldn't be a surprise that refugees and asylees who experience torture are 4 times more likely to develop PTSD and 2.5 times more likely to experience depression than refugees and asylees who did not experience torture. While some traumatic events, like malicious and intentional human-made disasters, are similar to torture in that they involve disempowerment and hopelessness through the installation of fear and terror, torture specifically involves repetitive, systematic, and organized malicious acts intended to humiliate, degrade, and disempower the individual by taking away their sense of self, their personhood, and their will. Both torture survivors and survivors of other types of trauma may experience depression, anxiety, and anger, and violent outbursts towards family members. However, because torture leaves survivors feeling like shamed non-humans who merely exist, once the torture has ended, survivors who have made their way to the U.S. often present with severe adjustment-related issues. Uncertainty about the future is standard among survivors of all types of trauma. However, for refugee and asylee torture survivors, uncertainty is grounded in the tangible reality of being sent back to the country where the torture occurred. Likewise, distrust is common among most trauma survivors. However, as Porter and Haslam wrote, no diagnostic terminology encapsulates the deep distrust of others which many torture survivors have developed, nor the destruction of all that gave their life's meaning. This is to say that while torture, trauma, and other types of trauma share many of the same symptoms, symptoms among torture survivors are significantly more severe, which explains why 20% of survivors of different kinds of trauma develop PTSD compared to 90% of torture survivors. Like symptoms, torture trauma and other types of trauma share similar risk factors like poverty, unemployment, and isolation. However, chronic pain is the best predictor of symptom severity for torture survivors. Pain also triggers intrusive memories and flashbacks. When mental health care providers develop a level of expertise in the following areas of competency, it is easier to build rapport and provide effective and appropriate services to refugee and asylee patients. Of course, first, it is essential to determine if the patient is a survivor of cultural trauma, such as war, terrorism, genocide, government oppression, and torture. However, it may be challenging to determine if refugee and asylee patients are torture survivors, as they tend not to disclose this information, but especially not during their first session. Recall, distrust is a significant issue. It may take time for the patient to sufficiently trust the therapist, or they may not be emotionally prepared to discuss the topic of torture. Nonetheless, research suggests that you offer an invitation to discuss it and allow the patient to bring it up when they are ready. Next, know how to use cultural brokers. Cultural brokers are individuals within the community who can help interpret and serve as liaisons between the patient and therapist. Remember, standard protective factors such as financial resources and social support are often lost when the individual flees their home country. Even basic communications in English can be challenging. It is also essential to know how trauma is regarded by the patient's culture. Culture can influence how trauma survivors assign meaning, convey symptoms, and develop coping strategies. For example, anthropological scholars studying Cambodian refugees found that the culture interpreted trauma symptoms as spiritual possessions. Torture survivors in Southeast Asia believe that suffering in this life brings greater rewards in a subsequent life. And overall, individualistic societies tend to put the needs of a person over societal expectations. Reversely, collectivist cultures tend to put societal expectations over the needs of the individual. From the previously mentioned countries of origin graph, refugees and asylees from Iraq, the DRC, Somalia, Iran, Syria, Cuba, Eritrea are likely to be collectivist. Refugees and asylees from Myanmar and Bhutan are likely to be individualistic. And those from Ukraine are most likely to be a mix of both. Finally, it is crucial to differentiate PTSD from other trauma symptoms and other mental disorders. However, researchers argue that the DSM's diagnostic criteria for PTSD are simply insufficient to capture the severity of symptoms that torture survivors endure, nor is it adequate to describe the complexity of physical, emotional, and social effects. Further, some torture survivors may have severe trauma symptoms but still do not meet the diagnostic criteria for PTSD. This competency emphasizes the need for cultural brokers who are familiar with torture and trauma symptoms. In addition to disclosure and trust issues discussed earlier, clinicians may have difficulty assessing for torture. Westermeyer and colleagues attempted to evaluate refugees from Eastern Africa who were torture survivors. They used two types of assessments. The first was a direct question: were you tortured? The second assessment was a checklist of the 75 most common torture experiences. What they found was considerable disagreement between the two assessments. In other words, many participants who scored high on the 75-item torture checklist also answered the single question, were you tortured, negatively. So they had likely been tortured, but did not believe that they were tortured. The authors of the study posited that they first did not perceive torture as torture because their lives were already saturated with other types of traumas like armed conflict, trauma experienced during escape, deprivation, and different kinds of abuse. Second, the authors proposed that some perceived that the punishment was deserved because of their political or religious opposition. And finally, Westermeyer and colleagues submitted that they feared discrimination because of the political or religious beliefs for which they were punished for, or because they feared the stereotyping of tortured individuals as being physically, emotionally, and cognitively disabled would stereotype them as being unfit for marriage, parenthood, and employment. However, despite these disparities, Westermeyer and colleagues found a significant relationship between PTSD symptoms from the PTSD checklist score and the 75-item torture checklist. So, what we can glean from this study is that it may be necessary to conduct multiple methods of screenings and assessments to elicit information about torture trauma specifically. However, it is essential to remember that torture methods vary among cultures. Earlier, I mentioned a list of universal torture methods, but the 75-item torture checklist was tailored for Eastern Africans and included types of torture specific to their culture, such as having the soles of their feet beaten, forced teeth extraction, electrical shock, and extreme torture attitude changes, like from a friend to foe. One multifaceted assessment instrument called the culturogram can help mental health professionals map culture's role in a patient's life. While the culturogram is not specifically a torture or PTSD assessment, it can help inform other types of culturally sensitive assessments that the clinician can use as treatment progresses. I'm not going to discuss all of the items on the culturogram assessment, but the instrument in its entirety can be located online at the listed website. The cultural context and the meaning of the torture experience differ significantly among torture survivors. Therefore, it isn't surprising that cultural norms would influence coping strategies. Idioms of distress were first defined by Nietzsche as ways in which people express, experience, and cope with feelings of distress. For example, individuals from Ukraine typically respond to trauma with stoicism and the excessive use of alcohol. Individuals from Myanmar are often reluctant to utilize social supports to cope with trauma. Instead, they rely on meditation and religion for self-reflection and mindfulness. A study with Iraqi refugees in Jordanian camps indicated that older, single, female, educated refugees use problem-focused coping strategies, while unemployed but educated females often used active emotional coping. Older, illiterate, unemployed male refugees tended to use avoidant emotional coping. I found this research particularly interesting because it illustrated how personal and social factors impact coping. A study on Bhutanese refugees found that most employed positive coping strategies, such as yoga and walking, attended healing spaces like temples and other sacred sites, participated in religious rituals and customs, and they were especially diligent in seeking social support from family, friends, leaders, and mental health professionals. Even Bhutanese youth also tapped in to social media via electronic technology to reach out to peers and counselors. However, a small percentage engaged in maladaptive coping strategies, such as drugs, alcohol, gambling, and suicide. The Congolese rely heavily on their faith and religious institutions to help them cope with the atrocities of civil wars. Their faith is connected to a belief that a higher being, either God or Allah, sent them hardships or challenges by which to accumulate mental strength. By being patient, their circumstances would improve with time. Their faith communities represent cohesiveness, support, and security, where Christians and Muslims often join together to share their experiences in the Congo. A woman living in a Kenyan refugee camp who had been abducted and repeatedly raped by rebels when she was young, noted, "Every time I think about that time, it is horrible. I don't know how to get through that, but in my Congolese church, I can survive and I can walk. It is my church that helps me. When I hear the word of God, this I can see." In addition to faith, the Congolese tend to compartmentalize difficult memories. Researchers have found that this has proven to be an adaptive coping, as compartmentalization is a way the Congolese manage memories by creating safe spaces and times in which to remember. "Blessed is the one who survives his misfortunes" is a common proverb in Somalian culture. Similar to the Congolese, Somalians view suffering as a test of faith and therefore turn to the Quran and Islam to overcome distress, find meaning in traumatic experiences, and connect with spiritual healers and rituals, which can include ceremonial dancing or exorcisms. Their devotion to religion, especially during times of strife, is likely driven by the belief that an emotionally broken individual is more vulnerable to evil spirits, specifically the jinn. Therefore, most often Somalians cope with distress through prayer, adherence to the Islamic religion, and engaging in acts of kindness. Two separate studies of Syrian refugees in camps in Turkey and Jordan both revealed that avoidant coping was utilized. Avoidant coping involves changing behaviors to avoid feeling or thinking about anything to do with their trauma, and it is considered maladaptive because it exacerbates traumatic stress. "I work all the time. Maybe I'll work in order to forget all these bad memories." This was the sentiment of a Cuban immigrant when asked how he coped with traumatic experiences. Because Cuba is a collectivistic culture, the family, which represents commitment, loyalty, and dedication, emphasizes the importance of support. However, one study indicated that males in particular believed that emotional issues were personal and not to be shared with others. Nonetheless, the Cuban culture in general tends to employ a broad range of adaptive trauma coping mechanisms, such as active coping, religious rituals, positive reinterpretation of trauma, emotional expression, and self-affirmation. One study of Eritrean refugees living at a camp in Ethiopia found that Eritreans typically employed a sense of coherence, which reflects an individual's capacity to deal with traumatic stress by comprehending, managing, and making meaning of trauma. They also utilize task-oriented coping, where the individual attempts to solve the negative impacts of trauma, and emotion-oriented coping, where the individual tries to minimize the impact of trauma through emotional expression. The authors found that Eritrean refugees who employed these collective coping mechanisms had fewer post-traumatic stress symptoms and depression. Another study found that Eritrean refugees at camps in Norway reported coping with trauma by focusing positively on the future through fellowship with other refugees and their religion. Iranian refugees also tend to utilize a sense of coherence with a strong focus on meaning making. When speaking of torture survivors in general, Several studies have indicated that connecting with social support and adherence to ideological or religious commitments were common coping mechanisms. While research has found torture survivors to be more resilient than survivors of other types of trauma, they tend to reach their threshold of resilience more quickly. So mild traumas can trigger a last straw effect. Styles of verbal and nonverbal communication vary from culture to culture in terms of direct communication, parameters of physical contact, personal space, body movements, gestures, eye contact, degrees of formality or informality, and acceptability of confrontation. High context cultures, which are typically collectivist, apply greater importance to the context of verbal communications and nonverbal cues. For example, high context cultures may encode sensitive verbal communications to avoid offending the therapist. Therefore, mental health professionals must recognize the context of the communication rather than the literal meaning. The way something is said or what is unsaid is often more important than the words used to communicate the message. Low context cultures, which are usually individualistic, are more explicit and direct in their communications to avoid confusion. Low context cultures typically do not prefer periods of silence or expressive body language. However, most cultures cannot be strictly categorized into the high context or low context category. Instead, they exist on a continuum. While high or low context categorization is a starting point, therapists should not assume that a patient has a particular communication style based solely on their culture. So, here are some do's and don'ts when communicating with clients from different cultures than yours. Avoid using psychological jargon. Addressing patients informally until you are familiar with their cultural preferences and expectations. Using terms and statements based on preconceived ideas created from sessions with other clients of the same culture. Downplaying or ignoring the relevance of traditional cultural practices. Downplaying or ignoring the importance of the patient's cultural identity in the therapeutic relationship. Neglecting the patient's individual and cultural history and background. And using nonverbal communications without understanding their cultural meaning. Things that you should do is adjust to the patient's verbal pacing, or in other words, allow them time to respond. Draw or show pictures. Provide manageable amounts of information at a time. Promote autonomy and empowerment, and try to mirror their verbal and nonverbal communications. And you can do that with this short exercise. So this communication assessment is to be done for both you and your client. First, you want to place an X on the line that best represents your communication style. Then place an X on the line that best represents your patient's communication style. Then consider if and how misunderstandings could occur due to these differences and how they may impact the therapeutic process and relationship. Other things to consider when evaluating communication styles are: what are appropriate situational cultural parameters regarding touch? Think about handshakes with individuals within the culture and outside of the culture. What are the appropriate cultural parameters regarding personal space? Again, what may be acceptable between two people of the same culture may not be acceptable between two people of two different cultures. What verbal and nonverbal behaviors could potentially harm the therapeutic relationship? And are there differences in nonverbal and verbal communications within the cultural group? Many non-Western cultures have adopted the belief that mental problems are attached to spirit possession, the evil eye, a lack of faith, and bad karma, resulting in personal and familial shame and loss of faith. Stigma is often nurtured by fear due to a lack of understanding and information on mental illness. Therefore, stigma is a significant barrier to treatment for many torture survivors. However, for torture survivors in particular, the Center for Victims of Torture recommends refugee and asylee community psychoeducation and sensitization sessions aimed at normalizing the feelings of trauma survivors and mental health care services. Role-playing and dramatizations help make problems more straightforward and accessible. Parenting classes has also enabled mental health professionals to reach trauma survivors as it provides a safe space for trauma survivors to talk about other problems. In addition, integrating mental health services with other refugee and asylee services, such as spiritual and religious centers, community service, and medical treatment centers, tends to make receiving mental health care services less stigmatizing. This concludes the presentation. Thank you for your time and attention, and if you have any questions, feel free to ask or contact me via phone or email.